Good afternoon, everybody. Hi, I'm McKay Jemison. I'll be moderating today's panel that's brought to you by the Pioneer Life Science Initiative. With me is a great foundation, Bill Smith, who's with the Pioneer Institute, Peter Pitts, who is with the Center for Medicine and the Public Interest. I was struggled with that one. And then Robert Popovian, who's with both Pioneer as well as Global Healthy Living Foundation. We're going to talk about a handful of really important issues that are impacting the life science and biopharma sector. And we're going to hit the ground running because we got a lot to go through in a short amount of time. So
if they have questions, they can put
if you have questions, please, and you're online, please use the chat function. We will get to those questions. But we're going to go pretty rapid fire through a handful of issues that we think are going to be really relevant and important. When we started this year, I was told it was not going to be a big year in healthcare. And then all of a sudden, within the past week, it seems like there's been a flurry of activity in healthcare. I'm not sure it's always covered in the media because of other debates that are going on in politics, but there's some pretty important pieces of legislation that are happening. One I want to start with is related to the quality adjusted life year, the QALY. That is a bill that is really important to basically removing QALY and similar types of discriminatory measures from federal health programs. I want to turn it over to Bill Smith, who's actually written a book on the QALY, quite literally, just to talk a little bit more about what is the QALY. I think historically it's sort of been used as a tool, but increasingly disability advocates across the country are viewing it as discriminatory, and what's the next step here?
Yeah, so I think it's kind of encouraging that the Congress, the House at least, is taking up a ban on the QALY. There's something cultural in the United States that steps back and says, no, we can't do this to people living with disabilities or with rare diseases or that have these specific medical conditions. In the European context, virtually every country, Germany being one big exception, but virtually every country uses the QALY and doesn't find it problematic. And in the U.S., I think they've particularly Congresswoman McMorris Rogers has really honed in on a lot of the problems in the QALY, and the biggest being that it is discriminatory to people who are living with disabilities. There's just no doubt about that. People living with disabilities are always going to have quality of life issues, which means their therapies are always going to get a lower QALY score, and that threatens their access. So, I'm quite encouraged that there's been this resistance in the U.S. to this.
Yeah, and the news is last night this bill went through the Rules Committee. It's expected to the House floor for a vote, most likely tomorrow morning.
And it's a bipartisan bill.
It's not currently a bipartisan bill.
It will be.
That was what I was going to actually raise next. We're certainly hoping that we will see greater bipartisan support. Bill, I don't know how much you've been following sort of the differences of views on this topic. The White House actually just put out a statement yesterday opposing the bill, mostly based off of the pay for. There's been some concerns that it may undermine the IRA, but I think that's been generally dismissed. But I don't know, Bill, if you have any additional context you'd like to share.
Yeah, no, I was kind of disappointed that the administration ended up opposing the bill, because in the past they've written things about the use of the QALY in Medicare and expressed a good deal of skepticism about it, particularly when it comes to people living with disabilities. So I was hopeful that they might actually support the bill, and that turned out not to be the case. I'm a little surprised by that, given their previous public statements about the QALY.
What's frustrating is that Michael Rawlins, the grandfather of the QALY back in NICE days in England, was very clear. He said the QALY exists because we can't afford to give everybody everything they need. It wasn't about effectiveness. It wasn't about comparative effectiveness. It was about controlling costs and rationing. And it's the right thing to cancel out, and to argue against it not only is unfair to people who are disadvantaged from the starting line, but it's also dishonest.
Yeah, and the QALY, in my view, not to get into the details, it's entirely subjective, because it puts a threshold value on the QALY on a person's life, and then you can move that threshold up or down depending on how many therapies you want to exclude. If you want to exclude a lot of therapies, just move it down and say a human life is only worth $5,000 and most therapies are not going to get paid for. If you move it up to 10 million, most therapies would get paid for. So there's an arbitrariness to it and a subjectiveness to it that's really troubling.
Yeah. And, you know, just to kind of level set too, you know, it's effectively already banned from Medicare. I think there's some potential to expand, not allowing it to be used in Medicare, but we're really talking about Medicaid, which low-income disability children are predominant on Medicaid, but we're also talking about programs like the VA as well. I don't know if you have any examples on how it's been used, particularly in Medicaid or in the VA, but I think that's part of this discussion that's not necessarily talked about.
Well, the VA definitely embraced it, and they've embraced it publicly, and then they went underground when they got criticized for using it. I'm very state Medicaid programs. ICER, who's the kind of promoter of the quality in the U.S., is a nonprofit, and it's based in Boston. And they've been, for a long time, ICER has been playing footsie with the Massachusetts Medicaid program. We actually put in a public records request, like the state version of a FOIA, and asked for all the correspondence between ICER and Mass Health, and they refused. They wouldn't give it to us. There's an exemption under the state law that if a policy is still under development, and I'm skeptical it's under development, but if the policy's under development, they don't have to share any materials. And so they rejected our FOIA request. So I'm a little concerned that ICER's gone to individual Medicaid programs and started to seed the quality as their cost-effective methodology.
As well as the VA, I believe. I think they've done that as well. Well, changing gears slightly, another area, I think in the spirit of ensuring people get the kind of care that they expect and deserve, PBM certainly have been getting quite a bit of attention. There's actually a markup today on a PBM bill in the Oversight Committee that's focused a lot more on delinking. I'd like to talk a little bit more about other aspects of PBM tools that lead to sort of exclusionary behaviors, discriminatory formulary practices. And I know you've been doing some work and looking at formularies in particular. Love to just hear a little bit more about that work.
Sure. So what we have done is we've looked at formulary exclusions from a patient's perspective, and the drugs that are excluded, the formularies were originally intended to make people use the most cost-effective medication, to get doctors prescribing generic medications instead of brand name medications. And they've really morphed over time to become a tool for pharmacy benefit managers to maximize the rebates and the discounts that they receive. To the point where we now have, in 2022, there were 2 medications that were excluded with no substitution, meaning that patients who were prescribed those drugs simply couldn't get treatment through their insurance. That actually has gone up. It went up by 120%. There are now, I think, 9 of those drugs that simply have no substitution. A number of the other substitutions are substituting a brand name drug for a brand name drug rather than a generic for a brand, which means we don't really know if it's cost effective. And part of why we don't know if it's cost effective is because the rebates and the discounts that PBMs receive from biopharmaceutical companies are not public. So the real price of a drug is completely unknown. And that gets to the issue of, whether capping drug prices really matters, because we don't know what's really being paid by insurance companies for these drugs. Ultimately, what we found is that about half of all exclusions are either not medically beneficial to patients or not necessarily medically beneficial because they're substituting a different drug than what the doctor prescribed, or they're not economically beneficial because, again, they're substituting a brand for a brand, or in some cases, they're even substituting a generic for a brand for a generic. So the generic is excluded and the brand name drug, which is definitely going to be more expensive, is covered. People will argue that these exclusions affect a small number of people.
Mm.
That they're for rare conditions or that they're for conditions that for a very severe disease that needs very advanced medications. We did an analysis at DHLF that Dr. Popovian and I conducted together with our colleagues. And what we found is that one exclusion of an anticoagulant could affect as many as 1 million people in terms of discontinuing medication and increasing the rates of stroke in a 6-month period. So the effects of these exclusions are not small, and they really are not benefiting patients in at least half the cases.
It's also very true within kind of the narrow therapeutic index drugs, drugs for seizures, drugs for antidepressant, where even a slight change in the bioequivalence rate can have significant, patient outcomes.
Absolutely, yeah.
And Wall Street Journal actually had an article earlier this year that GSK basically removed the brand name from introduced the generic for a 30% discount. And with them happening to PMs, this is a very common drug. Bill and I did a podcast with an individual who's depending on have normal, and he said he wanted to get his drug. It's an asthma drug. It wasn't available. So he had to switch and go back to his physician and get a different drug. These costs that have incurred. Why? Because the PBMs were very transparent. They weren't going to make as much money on the generic version of it than they were on the pending drug, even though the generic version was 35% cheaper, which is for all of us who have a deductible or a co-insurance, it would have been less expensive for the patient.
And a lot less green as well, not moving away from albuterol.
Exactly. So in other words, these are harming, this is like real life examples that are now coming up, not with like drugs or uncommon drugs that are used. This is a massive drug that's being used by a lot of people for asthma, and it's creating havoc in the marketplace. Why? Because the PBMs would rather exclude the drug because they're not making as much rebates on it, even though the generic version is 35% cheaper in retail price, which
And
benefits patients.
this is also happening with biosimilars. There is one biosimilar that's produced in 2 different versions. It's the exact same drug compound. It's the exact same biologic compound. One version is priced at a certain discount. Another is priced higher. The formularies exclude the lower priced in favor of the higher price. And that's just, they're given different drug codes in the database, but the manufacturing process, everything else is exactly the same. So it really shows you the irrationality of these exclusions from the patient's perspective, from the end user's perspective. And because of copays and deductibles, these costs are getting shifted onto patients more and more. So it's really as if patients are paying the discounts and rebates that PBMs are getting out of pharmaceuticals.
And it really hasn't been well covered. The IRA has gotten a lot of attention for the price control provisions, which for good reason. But it hasn't got much coverage that the IRA shifted a lot of costs onto plans.
Right.
And costs, catastrophic costs, many costs. Plans are going to have some financial pressure put up on them because of the IRA. The only option for a lot of these plans are going to be some of these utilization management techniques, the exclusions, prior authorization, step therapy. I think seniors are going to be surprised at the amount of access restrictions that emerge coming out of the IRA in their health plans.
And it's a disincentive to manufacturers to actually play this game as well. I mean, I don't know whether the biologic you're thinking about is insulin, but insulin is a great example because you have companies, Lilly is one, that has a non-branded, less expensive program that simply isn't getting picked up on plans.
Exactly.
And that's a direct contravention to what everybody is saying should happen. But if the math doesn't work, if the coffers aren't refilled on the backs of expensive insulin, not interested.
Now, one of the things that also number of exclusions, I mean, have skyrocketed, right? We went from like a couple of dozen to thousands now that are being excluded from the formularies. So utilization management is going to get ratcheted up. Bill and I believe that. And I think it's going to make things more difficult for patients to access. But this GSK example I brought, it was an authorized generic. It was being manufactured by the same manufacturer that was manufacturing the brand name drug. And you're talking about the insulin product, which is the same
Same
thing.
proposition.
Same proposition. And there's the hepatitis C drugs, same proposition. Gilead brought up a authorized generic. Authorized generic was excluded in favor of the brand name drugs. Why? All of these reasons is because formularies are no longer meant, what Anne started with, to do what they were initially intended to do. They're becoming profit maximizing machines.
And as you move into more and more discussion of biosimilars, which is a very expensive proposition.
Right.
If you're not going to have a significant market share, these products aren't going to exist.
Right.
One thing, I want to get to solutions on this in a second, but before we do that, I want to make clear too, a lot of what we're talking about certainly is happening with government payers, but it's happening in the commercial markets as well, Robert. I know we've talked quite a bit that even employers, that they may not even know some of these tactics are being used with their own employees. I don't know if you could speak a little bit to.
They don't. And really what happens is that there's this common ones that you see is like accumulators or maximizers. And I know there's a court case that sort of bans accumulators from being implemented, but Bill and I and Ann and I have done studies on this issue. Accumulators were going away anyways. It was the maximizers that were increasing in the market share. And there were, if you believe what Adam Fine puts out, is 70% of private employers have some type of a maximizer program now in their implemented. But employers have no idea that they're signing up for these things. And because why the language is buried in these contractual agreements, and when the patient shows up at the pharmacy counter, then they realize that they have this type of program that's impacting them. And that the biggest issue is that every dollar spent, whether it's through coming from a charity or coming from pharma company, does not apply to their deductible. And it's a big problem for patients, because one of the things that they've done with maximizers to say, okay, you'll be covered for your drug. And we wrote a paper called Pirates, Out-of-Pocket Pirates. And in it, we did analysis that shows, yes, your drug may be covered now, but because none of this money is applying to your deductible, you're going to be on the hook for all the other cares and services that you were basically being covered for through this deductible payment. So yeah, employers have to take a more active role in the care of what they're signing up for, but it's really difficult because a lot of them depend on agents and things like that, brokers, which they themselves, they may not know, or they're incentivized to not talk about it because they're getting paid by the PBMs and the insurers.
That's why I wanted.
We've gone from 588 exclusions in 2021 to 690 some exclusions in 2022 to now 768.
Right.
My numbers might be off by a couple here or there, but the increase in exclusions has been 30% year over year from 2014 to 2022. It's actually started to plateau a tiny bit, but I think that the pressure that the IRA will put on pharmacy benefit managers and insurance companies is actually likely to make the formulary exclusions start increasing again. And that's too many drugs for somebody to go through to figure out what is and what is not covered.
Right.
And patients go to their pharmacy, they pay a huge copay or portion of a drug. They go back again to get it refilled. They think they've spent the $2,000 deductible, and then they go to get an MRI and they find out that they still owe $2,000 because of these maximizers. So patients don't know until they're presented with the bill, and that's really harming people and increasing medical debt.
It also points out to Robert's point that the person at an employed company who has hired a PBM, until their employees start walking to HR saying, hey, what's going on with our insurance plan? They haven't given it a moment's thought. They're all looking at what their annual increase looks like.
So that's why I wanted to bring this up too, because I have a little bit of sympathy, I think, for the employer. I do agree with your point that they need to be a little bit more sophisticated as they're looking at tools. But I also think, particularly when you're talking about the small and mid-sized employers, they're trying to run a business, their actual business, and then they're also trying to manage a healthcare business on
Right,
top of it
right.
as well. And I think that is a tall ask for a lot of these employers. So in that spirit, I wanted to get a little bit more towards a conversation on legislation, regulation of sort of these PBM practices. What does that look like? What's sort of the outlook for, this year, maybe the next 18 months?
So some of the legislation that is, there are a number of bills calling for more transparency of what PBMs do, saying that they have to make public their discounts and their rebates that they're getting from biopharmaceutical companies, or that those discounts and rebates have to be available on request. And transparency is good. Don't get me wrong, but it's really not enough just to say they have to make the information available, because most people are not going to have time to look that up. It will make it easier to put in other regulations down the road that will impact patients and help patients. So I think the transparency, the laws that will increase transparency are good. I just don't think they're going to make things much better.
Well,
in the short term.
transparency is good 100% of the time.
Yeah.
But the nub of the problem is, when is a rebate not a kickback?
Yes.
Right.
And it's when the government says so.
Right.
And under the Trump administration, there was at least a brief glimmer of discussion about reversing this safe harbor, where it's not a kickback because we say it's not. That's not being discussed, and that's a shame, because that really cuts at the heart of the problem.
I think the Federal Trade Commission investigation into PBM practices in some ways is more fruitful.
Yeah.
And again, transparency is good 100% of the time, and those laws are a great thing to pass. We just need more.
I'd be curious, and this kind of goes back to the point on commercial as well, because I think from what I sense within Congress, there's more comfort when it comes to looking at sort of the government payers, a little bit more reticence when it comes to regulating the private commercial markets. Just be curious on various perspectives from this panel on that, particularly.
Go ahead.
Okay, well, the legislation really is designed to control the government market, right? I mean, they don't have fortitude to go beyond that. IRA is the same way. It's controlled Medicare prices. It's not going to go to the commercial side, but we all know as soon as they set the prices on Medicare, that's what's going to go into the commercial payers. The commercial side will adopt to it. So here's my take on the PBM bills. Number one, transparency is the starting point, but you need the transparency. Why? Because you need to actually know the data, the real data, that it doesn't exist
In real time.
in real time. So there are organizations like SSR Health or IQVIA that do all this modeling, and we've done it. Bill and I have done it with Pioneer. Wayne and I have done it with the Pacific Research Institute. But it's not real data. It's all modeling. And in fact, if you talk to CBO and you really talk to their staffs and you talk to anybody within the government, the CMS and HHS, they don't even have the real data, because a lot of times the legislation through Medicare Part D is a perfect example. They're prohibited from collecting that information from the PBMs, and PBMs don't have to supply them. So what has happened over time is that, yes, they have to provide the rebate dollars, right? But we all know that the rebate, and you look at the most recent report that came out late last year from Nephron Research that showed that, yes, rebates are still a big part of it, but fees are exploding. They're increasing in fees, and there's no legislation or regulation that mandates that they have to report the fees back to the employer or to the federal government. And in addition, what has happened over time also is that with the PBM consolidation and purchase of the specialty pharmacies, they've captured all of that market. So now my understanding is a lot of the contractual responsibility has nothing to do with rebates. It's paying, pharma companies have to pay the specialty pharmacy, which is owned by the PBM, a fee to cover this medicine. So in other words, they've become such an integrated part and consolidated that they're able to keep the money and hide it from everybody else. And the best thing that I can say is, like, it used to be a time where the insurers, who were the plan sponsors, were sort of the gatekeepers. They were, they made sure that every dollar collected by the PBM actually went to the insurance company. And then what the insurance company did with it, fine, it lowered the premiums. But now, because of this vertical integration, is like one hand passing it back to the other hand, and nobody knows what it is. So transparency is super important to start with. And unless you have the real data, we're just going to make these assumptions. And the second thing is to say what we need to do, which is there's a lot of controversy around a lot of like conservative groups, actually, Bill, I want you to talk about what Breitbart is doing. A lot of conservative groups are hammering about not delinking issue. The delinking is the key here, because if you delink the fee from the price of the medicine, there will be less incentive for them to cover that more expensive medicine. Because right now the incentive is all in the market to have higher price medicines, higher rebates, higher fees. And we need to get away from that. And one of the ways to do this is to relieve delinking. Bill, you want to talk about it?
Yeah, no, I was just going to say, we've noticed that in the conservative media, PBMs are sponsoring op-ed pieces and other articles to say PBMs are the fiscal gatekeepers for the federal government. They reduce the deficit, they cut spending, and they're very conservative organizations. Is basically
That's right.
they don't kind of talk about favoring the most expensive drugs and all these other things. They just basically say we're their fiscal watchdogs, which I thought was very interesting campaign.
And in one of the articles, a congressman from Ohio was quoted as saying how PBMs should not be touched and no regulation should be put up on them. And it's really interesting because Ohio is the epicenter of all the problems with PBMs, right? With spread pricing. That's where the whole thing started, where there was in 1 year, they overcharged the state Medicaid program over $100 million through spread pricing for generics. And we're not even talking brand name drugs. And, Bill and I wanted to call the congressman and say, maybe you want to just check with your AG in your state and why the Republican attorney general is suing the PBMs in the state of Ohio.
But they're scared, Bill, because to your point, all of a sudden, even when the lowest common denominator transparency bill start getting traction, all of a sudden, the op-eds start popping up and the hate mail to me and to us start to ramp you up. They're scared, and they should be scared.
Yeah. And some of these bills do include some anti-spread pricing conditions and some anti-steering conditions, which is really the other thing to talk about, is that these PBMs, in addition to formulary exclusions and spread pricing, they're also steering all of the purchasing through their own pharmacy.
That's right.
So the fee that the pharmacy pays to the PBM is really the PBM paying itself.
Yeah, and there's evidence that because Free Access Advisors has done a lot of this work, Brooklyn 46, and they publish it. There's a lot of evidence that PBMs pay differently. To their pharmacies versus other specialty pharmacies, and there's fees involved that are different, and the price is not the same across the board. So when that happens, there's a lot of gerrymandering.
And it also impacts supply to pharmacies that don't play nice.
That's right.
Well, definitely distortions in healthcare is not particularly new, but it's definitely seemed to exacerbate, I would say over the past decade or so. I think another area where we see that's in charity care. And particularly in the 340B program, Bill, I know this is an area that you've worked a lot. Pioneer has a tool that looks into the relationship with 340B and contract pharmacies. I'd love you to tee up that issue.
Yeah, no. I encourage everybody online and in person to go on the pioneerinstitute.org website. And at the top, you'll see 340B, and you click on that and you get our online tool. And with that tool, you can see the growth over 10 years in 340B pharmacies, where they're located. You can click on state legislative districts, state assembly and state senate districts, and you can see the number of 340B resources in each of those districts. And you can also click on a charity care portal where you can look at charity care being given out by 340B hospitals all around the country. And since you asked specifically about charity care, I will say that the trend clearly, and this isn't the case with every 340B entity, but the trend clearly is, as the 340B program has exploded with growth, and as 340B revenues for hospitals and clinics has exploded, charity care has declined simultaneous, which is not what you would expect, given the amount of revenue that these entities are securing through the 340B program. One would have expected charity care to take off, but in most cases, and again, there are exceptions, there are hospitals that are doing the right thing and trying very hard to support the community with charity care. But in general, what we're seeing is major declines in charity care spending.
And it's no longer a secret, huge government program. Patients are recognizing that it exists as well in strange places. I was at a meeting the other day about the enormous overhead costs that hospitals charge for clinical trials. And somebody said, well, why don't you take it out of the 340B pot? So it's known that hospitals are making a killing and they're not plowing it back into anything, let alone using it for what it was intended.
Yeah, I mean, the incentives in the program are completely misstructured. If a 340B hospital can buy an oncology drug that lists at $100,000 and they can buy that for $25,000, all the incentives are for the hospital to bring in a Medicare patient or a patient that has very good insurance, buy the drug for $25,000, bill the patient's insurance for $95,000 and keep the spread. There's no incentive for them to give that $25,000 drug for free to an uninsured patient. That just costs them $25,000. So all the incentives are misaligned in the program, and that's what's accounted for its substantial growth because it's become a revenue source for 340B entities. And what we've seen is 340B entities move into wealthy neighborhoods, affluent communities where people have good insurance, so they can arbitrage the discounts that they're getting in the program. The program is really out of control and needs major reform.
And the explosion in 340B consultants, to hospitals.
Yes.
So,
Go ahead.
sorry, McKay, I want to give some flavor about what's going on in the states though, because this is a federal program, but several states have decided to step in and introduce legislation of some type. And it's becoming very obvious that the legislation is trying to put prohibition of any kind of data requirement. Basically saying that nobody can ask any questions and provide, you cannot have as a provision of data as a requirement for the 340B discount. So just to give you guys some flavor. So for transparency purposes as Pioneer, we're testifying today, actually at the Oregon state. They have a legislation that does one of these prohibitions. Just to give you an idea with Oregon, almost 50% of the pharmacies that are contract pharmacies that are contracting with covered entities within the state of Oregon are outside the state lines. That means they're all over the place. They're in California and Hawaii and Pennsylvania and South Carolina and Florida. So the other one is the common thread that you see commonly, and this is, we've done the analysis for multiple states, is that this has become a moneymaker for PBMs. If you look at each state individually, in most states, the top 5 pharmacy with the most contracts is a PBM-owned pharmacy. So it's either Optum, Caremark, or through Express Scripts. The other trend that you see, and Bill alluded to, is that in New York State, for example, the top 5 hospitals in New York, they, from a revenue standpoint, they provide less percentage of their charity care is less than the average for the state and significantly less than what the average is for the country. So these are important trends to keep in mind, that this has become another moneymaker for the PBMs. You're not talking about individual independent pharmacies that are operating in the community that are helping patients out. These are not located in poor neighborhoods, they're in affluent neighborhoods, these pharmacies. And also that the charity care is not being provided at a higher level. And the other thing I want to mention, the tool is important for people to know, is that number one, it's been updated now all the way to the end of 2023 with data. The data that we use for the tool, anybody can access it. The first part of the data about the 100 pharmacy issues, all from HRSA. So this is anybody can go and download the data and do the analysis themselves, but you can go to our site at Pioneer and look at it yourself. And the second part, the charity care data, is from Rand Corporation. So when Bill and I were talking about developing this, initially CMS supposedly is collecting this information.
And IRS.
And we decided against using that because what Rand has done over the last several decades is collect this information from hospitals with regards to the percentage of charity care they provide. And they normalize it for all the discrepancies and everything else. So we have purchased the data from Rand and we've updated the database. So this is not Pioneer data. This is not some proprietary data. It's coming from HRSA or RAND Corporation, and anybody can have access to it. What we did with the tool is just make it easier for people to use it and do the analysis.
Any other states on your list that are good?
So there are bills right now, active bills in Oregon and New York, as far as I know, but I know that there's bills passed in in Louisiana and I believe Arkansas. But there's, so most of them are prohibiting information, which doesn't make sense to me, is that
Right.
all these bills do is protect PBM loan pharmacies, for-profit pharmacies and chain pharmacies. Because at the end of the day, all pharma wants to do is to say, you give me the data that shows that you're actually supplying what Bill was saying, supplying the 340B patient, then I'll give you the discount and I'll give you the discount. Nobody's opposed to that. But prohibition of information flow is one way to stop this. And who's benefiting from this? Again, the PBM loan pharmacies and the big retail chain drugstores. If you actually look at go out to our database, if you look at the contract pharmacies with the most contracts nationally, of the top 12, the first 2 is Walmart. The next 10 are PBM loan pharmacies. This is not a small business. You know, it's not Peter Fitz's pharmacy.
In upscale zip codes.
Right, upscale zip code. This is not Peter Fitz's pharmacy operating in Bronx and helping the Bronx patients. This is big business for PBMs operating in very affluent neighborhoods.
Policymakers are beginning to catch on to this. Senator Cassidy wrote to the CEOs of CVS and Walgreens and demanded to know how much revenue they brought in from the 340B program. So people are beginning to understand there's a lot of for-profit actors that have gotten into this space that are making a heck of a lot of money. And the uninsured and the underinsured, they're not getting as many discounts as one would expect in such a lucrative program.
And there was a bill that was introduced either last week or 2 weeks ago, I think, at the federal level as well to, I think, try to strengthen the program, right? What is the solution here? I've always thought it's a little bit of accountability, transparency.
Yeah, that's why the states are going in the opposite direction when they're denying data. The best thing that could happen in this program is for hospitals and clinics, 340B entities, to disclose how much revenue are they making from the 340B program and how much charity care are they giving out under a uniform definition of charity care. If you could compare those two things, you would know which entities are doing the right thing, serving the community, giving out lots of resources, and ones that were not, that were padding their executives' pay or doing something else with the money. That would be a first step in my mind. I wouldn't go in and cut the program right away because there are a lot of small community hospitals that do good work in the community, and you wouldn't want to deny them that revenue source right away. But if you get some transparency, you'll find the people that are doing the right thing and the people that are not.
And naming and shaming on the local level.
Yeah.
When state legislators see which hospitals are getting the money coming in and not providing quality charity care, but cutting charity care, they are astounded because they're their friends. They do the Little League uniforms. They contribute to their campaigns. They get upset and angry. And that's when change is going to happen, when on the local level, your allies abandon you.
And really, if you look at historically, this program was intended to help hospitals that were taking care of a lot of uninsured, right? Hospital where I trained under LA County USC, 90% of the patients when I was training were uninsured. They walked in, they got free care, and this whole program was intended to help those hospitals, and it has helped. The problem is that it's no longer the case. With ACA, passage of ACA, not as many uninsured exist. And in addition, these hospitals are really now profiting through these contract pharmacy locations. And because of lack of transparency, nobody knows who's at fault here.
Right.
Because when Bill and I have spoken to the CEOs of these hospitals, what they say is that, look, these contract pharmacies come after us. And when you talk to the contract pharmacies, they say, no, it's the hospitals that want these contracts with us. So nobody knows. So the lack of transparency is very beneficial on both sides. And these state bills really do what should be done the opposite way, which is create less transparency. And this program is a great program that needs to be preserved. And the other thing you always hear is that, well, this is helping for the underinsured or the people who are not getting better reimbursement in the rural hospitals and things like that. Well, that's a different issue. Then go address the underinsured or the payments to the rural hospitals. Don't try to put a Band-Aid on it by bastardizing a federal program.
But also, Bill hit it on the head. This isn't just about it allows us to buy new MRI machines, or it allows us to build a new pediatric cancer wing.
Right.
Executive compensation is always a nice indicator of how this money is being spent,
Yeah.
and that is public.
I do want to stick with the state theme because there is a lot of activity going on in states. I know one popular issue has been the prescription drug affordability boards, but I actually want to focus on a different issue because Florida really has kind of become an outlier as it relates to drug policy over the past 12 months or so. Peter, I'll turn it over to you. I think there's at least two things going on in Florida. I think the one that's making the most news at the moment's been Canadian importation within Florida. You want to talk a little bit about?
Sure. Well, I'm like the Cassandra of Canadian drug importation. I've been dealing with this for 20 years. I won a medal. I won a congressional medal of some kind. H.L. Mencken said that for every complex problem, there's a clear, simple solution that's wrong. And that's drug importation. And we talk about Florida first. So I testified in front of the Florida House in 2019 when Governor DeSantis was pushing this. And they didn't give me a lot of time. They gave me even less respect. But I did get a chance to say, hey, have you guys spoken to Health Canada about this? Have we talked to Health Canada about this? No, they haven't. I said, well, you better get that done. Because way back in my days at the FDA, Canadians were saying, we're not going to say anything until we have to. And then when we have to, we're going to shut it down. So as soon as Canada realizes that the Florida thing kind of sort of might happen, they just put the kibosh on. And I think not a functionary at Health Canada, which is the FDA equivalent, but the health minister in Canada said that the U.S. we're not going to allow the U.S. to pillage our drug supply. They're serious. The myth that the FDA has approved the Florida plan is linguistically incorrect. They've looked at the Florida plan. They'd said, if you can do these other very difficult things, you can probably go ahead. It's a long path ahead. And now Canada has said, we're not going to allow any of these products to go from us to you. Health Canada is a world-class regulatory agency, just like the FDA, but it's not identical. And Health Canada has said, we're not going to put our stamp of approval on any products that are sold outside of our borders. Then the population math is upside down. A country of 38 million people can't supply a state of 22 million people, even if it's a limited amount of drugs. The real danger is it sends the signal to the American public that it's okay to go back online to pharmacies. Maybe they're Canadian, maybe they're not. Every study of these online pharmacies comes back, they're not in Canada, they're selling counterfeit drugs, they're expired. It's bad karma. And what the American public doesn't understand, certainly people in Florida, is that if 90% of drugs used in this country are generics are actually more expensive in Canada than they are in the US. And Florida then said, well, we're just going to test this program on prisoners and people on Medicare and Medicaid.
Yeah.
I don't think that's a very good guinea pig population. There shouldn't be a guinea pig population. And of course, the state of Florida is accepting no liability for any mistakes that might be made.
Well, the interesting thing too is particularly Florida's Medicaid population, which is roughly about, I think it's about 5,500 or million. I mean, Floridians. That's larger than the average state in the United States. That's actually a massive population. When you really think
The thing about drug importation is it's a canard, it's a joke. The Congressional Budget Office has scored this a number of different times. The savings max out at like 0.01%. So even if you double it, it's 0.02%. It doesn't solve any problems, but it takes our eyes off the prize of workable, logical solutions. And it also simultaneously puts people in harm's way, pointing them to dangerous outside sources of products.
But what I hear you saying is it's functionally impossible, basically.
Well, first of all, the drugs have to come from someplace. They're not going to come from Canada.
Yeah.
So, oops, mistake number one. Mistake number two is if I go to the drugstore, if I'm a Medicare recipient, if I'm a Medicare recipient, do I get the drugs that came from Canada through the Florida plan? Is that in a separate pharmacy? Is there a Canadian pharmacy that dispenses Canadian drugs versus the red, white, and blue pharmacy that dispenses of FDA-approved drugs? It makes no sense. It instills no confidence. It solves no problem, and it causes a plethora of other problems.
The other thing Florida's looking at too is reference pricing. It's my understanding it's unlikely to pass this session, but that's a bill that's probably going to be taken on for a while. And I think whether we're talking about Canadian drug importation or reference pricing, I really think it's hitting on this bigger theme that I think we don't often talk about, which is the disparity in pricing between the US and Europe and other developed economies as well. I think a lot of this policy is in reaction to that and saying, why can't we get the same type of deal? Bill, I know you've been looking at how.
Yeah, no, this is I consider these importation and I don't mean to be
It's a
irreverent, but it's like carnival barkers support this kind of thing. I mean,
Bernie Sanders.
yeah, it's the reason why European countries in particular, but developed countries can get lower prices is because they're freeloading off manufacturers. So US consumers pay the lion's share of the R&D, which is spent upfront in the pharmaceutical world. It's spent before the product's even on the market. Unlike an industry like motor cars, where manufacturing is the high cost. Canada could not freeload off Ford Motor Company because if they said, we want to buy an F-150 pickup truck, but we want to buy 50% of the US price, the CEO of Ford would say, go pound sand, because 75% of our costs are in the manufacturing. So we're going to lose money on every truck. That isn't the case with pharmaceutical products. With pharmaceutical products, the money's already been spent. If the Canadians want to give only half the revenue and pay a below market price, it's a difficult decision for the CEO. They're not getting a fair price. On the other hand, they're going to give some revenue to the company, right? They're going to, pay $50 million for this drug. And the Canadian people are actually going to benefit from the drug. So it's a hard decision to say, no, we're not going to accept an unfair price. But it's basically freeloading. And naturally, many of the countries that have low prices on drugs also have very low defense spending and freeload off American defense budgets. The Canadian defense budget is like 1.4% of GDP, and the US's is 3.5% of GDP, and it's a massively larger GDP. So they're freeloading off American R&D, and they're freeloading off American defense. And the only way to solve this problem is for a president to step in and say, this is a real trade issue. Pharmaceuticals and biotechnology are an American industry largely, and that's still the case. And you're paying below market prices and you're freeloading off the American taxpayers. And you need to give these companies more revenue so they can do even more R&D than they're doing now.
Yeah. Reference pricing is a great argument because it's what we're not talking about that's crucial. On-patent medicines are less expensive in Europe because of the way negotiation systems work. Generic drugs are substantially more expensive in Europe than they are in the US. So if we wanted to adopt a European system, of course, there is no European system. It's country by country, oftentimes province by province in a lot of the European countries. If we're willing to say, we'll trade for the price differential for on-patent drugs that are miraculous, but we're going to double or triple the price of generic drugs, would that be acceptable? Certainly not, but we don't want to talk about that because that's too honest of a conversation. The real conversation is the rest of the world is freeloading on the backs of American patients. No American president has had the guts to address it. It's long overdue. It's only getting worse. And all you need to look at is the matchup between not just the price, but the access in Europe for these less expensive products, which is substantially less than it is here. What are we gaining? Everything in Europe relative to pricing is upside down. The Europeans recognize that. They're changing to different systems. We're looking to some fantasy system that never existed in the first place because it's a good political soundbite.
But
And I want to get back to Peter's earlier point about the Canadian health officials. They should be legitimately frightened of importation schemes, because what manufacturers will do if some wholesaler in Canada wants to send a big shipment of product to Florida, what manufacturers will do is say to that manufacturer, hey, guess what? We're only going to give you as many drugs as we gave you last month. So if you want to ship them to Florida, that's fine, but you're not going to have anything left for Canadian pharmacies. And that is a genuine worry for Canadian health officials.
And this was litigated, I think, in 2003. in Minnesota, Mike Hatch was the Attorney General of Minnesota at the time. He sued, I think it was GSK, for exactly that, limiting the supply to Canadians who were reselling into the US. And the court said GSK can do what it chooses to do with its product. You can't force a company to sell more if that product is being used in contrivance to their contracts.
Mhm.
Yeah, it's just not a workable thing.
But I have to challenge a couple of things. Number one, I think that it's a ruse, the importation thing.
It's a sleight of
It's a
hand.
sleight of hands, and the issue of pricing with regards to negotiation, to the government getting involved in forcing the Europeans. Actually, that was a proposal that came up during the Trump administration, and it ended up being international price indexing, reference pricing, right? It somehow got the what Peter said, it's a simple answer to a very complex situation because they didn't want to get into a complex thing. But I also have a tendency to challenge the idea that we're paying more for products because we have no idea what we're paying in the United States. That's the problem. Because of lack of transparency, because of the way we contract in this country through rebate contracting and fees and concessions and everything else, I challenge people to show me in what is the net price we pay for some of these medicines that are supposedly cheaper in Canada or in EU, because I'm not sure we know the data. We're just assuming we're paying more.
And this is the problem of focusing only on the list price
Right.
of the drug, right? And not looking at what the pharmacy benefit managers are doing, what is the real price that people are paid. And so all of these, even the IRA with its price caps on some of the most used drugs, that's not necessarily going to lower prices for patients. And so we really have to look at what is the real price. What portion of that are patients paying? What portion of that are the insurance companies paying? And we can't start making comparisons, real prices.
When you push kind of the IRA istas on this topic, and you say, well, how far? That's not the issue. Not if you're not paying, not if it is, if you're paying the copay, it's a big issue with a copay accumulator and it's never going down. It's an enormous issue. It is the issue.
Yeah, it is the issue because patients don't actually care. They don't need to know the list price. They need to know what they have to pay. What they have to pay is dependent on list price minus all the rebates, discounts. And that, I think, is where the focus needs to be.
So that I'll challenge people to tell me exactly. Everybody's assuming something. The only people know the drug are the PBMs.
So, and taxes they pay to the government to cover the government's participation in programs.
At the end of the day, we don't know. So I challenge people to tell me if
Q&A in chat.
okay.
I'd like to see if we can turn.
It's an audio comment.
Never mind.
We're all good.
Any questions from the audience? We got a little bit more, but since I just paused for a second, any questions from the audience? Okay. There's another topic that I want to go towards that I hope leads us towards an optimistic note. But the panel will dictate that. I've been looking at some public opinion polling. It's private, but none of this will shock anybody. American dissatisfaction of their healthcare system is high. It's continues to get a little bit higher every year. The concept of Medicare for all isn't necessarily as popular as what may be sort of projected outside. That said, there is some interest in some government intervention of some kind. But when you start to poll based off of asking questions around from an individual perspective, would you like to have more personal control over your healthcare decision making? Would you like to be enabled to have more options in healthcare? Basically giving power more towards the patient. That starts to poll very, very highly compared to these other aspects as well. And so I know we're starting to see some things like direct primary care, for example. We're starting to see avenues that are allowing people to just I think, have a little bit more control in healthcare. I'd just love to kind of talk about that trend a little bit and what we're seeing in the marketplace.
So, I mean, this is something that I was asked on LinkedIn because I posted about the issue of direct selling to consumers. The two companies that are selling or one company that is trying to sell the obesity drug directly to consumers. And the reality is that the consumer is becoming much more aware of how much they're overpaying for their medicines, right? That's why you see these cash pharmacies, whether it's the Cuban pharmacy, which is a small player, or Costco, which is about 40% of their business in Costco is cash-based. People pay cash for their medicines, are thriving. And the reason being is that the consumer is figuring out that they were overpaying by using their insurance card. So what I was trying to say on the LinkedIn, because somebody asked me, they said, okay, so do you see this as like a watershed moment where direct to patient is going to take over with regards to pharma companies directly selling to patients? I said, not really, because at the end of the day, this model was tried when Bill and I were at Pfizer. They tried to do that with Chantix. It didn't work for a variety of reasons because telemedicine was not as ingrained back then when Chantix was still a product that Pfizer was trying to use. But the bigger issue is that we are already seeing that people are bypassing insurance and going directly, either buying their pharmacy from these cash-based pharmacies, or they're buying direct primary care and bypassing their insurance model. So the question becomes, is that we really need to really think about what other things can we do to bypass this whole middleman environment. So is there an opportunity for pharma companies to directly sell to providers? So Florida cancer, you're very familiar with that because you're from Florida, but Texas oncology, I'm very familiar with. Texas oncology covers 50% of the patients in the state of Texas. Is there an opportunity for a pharma company to directly sell to Texas oncology and completely bypass the wholesaler model and save money there and save money for the Texas oncology, and then take on risk together with regards to the outcomes, instead of having all these middlemen basically making money here, 5%, 10%, 20%, 30%, whatever it is. So I think the consumer is already signaling that they're comfortable going out of this bubble of insurance to a different, and I'll give you my own personal example. So this year, we are paying just out of pocket for premiums, we're going to pay about $12,000. In addition, we have a $7,500 deductible that we have to meet as a family. So our family is going to be on the hook to close to $20,000 before we see a dime of insurance kick in. So my question is, why am I paying for insurance the way it is right now when I just need catastrophic care? Because if something really bad happens, then I can use it. But the way things are going for us, relatively healthy, we're probably going to spend $5,000-$6,000, and the fact that I'm never going to see an insurance model that helps me out. And I think the consumer is already signaling it. That's why you see a lot of discussion about bypassing it. Now, the pushback you get from PBMs when you say, patients are bypassing you and going and buying it from Cuban or from Costco is that, well, if they go outside the model, we cannot manage their care appropriately. And, we have these disease management programs. And that's why we have to charge so much more for the generic medicine, especially when it's pennies to the dollar. And my answer is that show me a single study that shows that a PBM disease management has improved patient outcomes, not pill counting, not that they've filled more refills and things like that, but actually improved patient outcomes. And then I'll believe that your rhetoric is correct and that the patient should pay more. And then the last thing is that, in my opinion, every dollar spent on healthcare should apply to your deductible, whether you're paying cash at the cash-based pharmacy or direct primary care, and you're paying your direct primary care directly out of your pocket, that should apply. And too bad for the insurance companies who don't like it, because they've created a model that it's unaffordable for the average person to afford healthcare.
Well, two things. Firstly, I'm looking forward to participating in the Potovian GoFundMe campaign. But I think you hit the key point, which is there are a lot of Americans, there are tens of millions of Americans, possibly more than, possibly hundreds of millions of Americans who exist in a cash-only economy.
Yeah.
And these types of reforms that we're talking about on the big level, transparency and safe harbor issues, they're all good and important, but it doesn't touch these people. You have to make sure that people can access healthcare the way they want, the way they can.
Right.
And if it's cash, they need to be rewarded for that. They,
Yeah.
or rather, because now they're penalized for it.
That's right.
And if it's through a physician dispensing, vets do it. You know, it's something to look at. It's something to think about. When you have a monopoly that disenfranchises providers who can provide everything except the medicines they prescribe.
Right.
It seems a little bit upside down. Many countries in Europe, physicians can prescribe, or physicians can own pharmacies.
That's right.
You know, there are lots of reforms that need to focus on the people who want alternative ways of not accessing, but paying for their healthcare. And we're just not talking about it
Right.
at all.
Yeah, I mean, Robert, you sort of took the words out of my mouth as well. I feel exactly the same way. I will never probably need enough health services to cover my premiums and deductibles.
Yeah.
And I definitely don't think you.
What
and
a
I are
racket,
one.
right?
Right. Exactly.
And what I struggle with is because I agree with the points of if I use my good RX or whatever, I should get credit for that as it relates to my deductible. I do agree with that, but I also think fundamentally our insurance system is based off of something that was designed in the mid 20th century. It was really designed to be a product sold to businesses to then insure their people. It was never designed around the patient to begin with, first and foremost, right? And fast forward now, we're in 2024. The advances we're seeing in science and technology and medicine are so advanced that the system can't even keep pace. And so I'm sort of like, we need to get into a really big reform mindset. And the problem is our system, which, you know, while we don't have a government run healthcare system, our health insurance system is governed quite a bit by regulations and government. How do we start to fix that problem?
Right.
Well, the first way to deal with it is to be honest about the language that we use.
Right.
And when we say one of the great revelations of the Inflation Reduction Act is it allows government to negotiate for prices, the government has always negotiated for prices. I mean, you know, the chutzpah to keep repeating this key talking point that has the problem of not being true and not having somebody call out the lie. I don't understand why that's not happening. And how do you get beyond that to more important things if we can't all agree that we should start by telling the truth about these topics?
I just think that we need more consumerism in healthcare. I think we got to be better consumers, just like we're buying our cars and our TV sets. We need to become much more aware as a consumer. And because of the plethora of information out there, I think we can become better consumers. We just need to be more vigilant. People are much more discriminatory behavior as a consumers when it comes to buying a cup of coffee than they're about buying which pharmacy they go to or whether they pay cash or use their insurance.
There's a learning curve. That's okay.
Right. That's okay. We'll get there. But I think the consumer signaling already that they're willing to do this. It's just that there's these huge entities that are blocking.
Yeah, and it used to be that employers were the gatekeepers on quality, right? You got hired out of college to work at IBM, you were going to retire from IBM. And therefore the company paid a great deal of attention to what your health benefit was because it's part of your compensation package. Now people are changing jobs every 2 or 3 years and employers are not as scrupulous about making sure that their benefit is a very high quality benefit. It's just the reality.
While at the same time, more healthcare does more things for more people. So the question as to why are we spending so much more on healthcare, the answer is because there's a lot more to spend it on. And that's a great thing, but you have to spend it right.
Well, I want to turn to the audience to see if there's any last questions before we wrap up, or if there's anybody online that wants to ask a question. No? All right, well, why don't we just end with maybe a final word from each panelist and wrap it up. Robert, you want to start?
Transparency in healthcare is important. I know that everybody argues that transparency is not going to lower prices, but unless you have the real data and you know what the data looks like, you're going to make the mistake over and over again by passing bad legislation, bad policy, bad regulation. Until you have the real data and the accurate data, you're going to be bound to make mistakes.
Yeah. Transparency, honesty, I'll vote for those two. I know this is naive, taking the politics out of it. Recognizing what systems have been tried and failed in other countries rather than thinking that we reinvent everything. Churchill said Americans always do the right thing after we've tried everything else. Yeah. We can't allow that to happen. It's too expensive. People's lives are at stake.
Yeah.
Yeah, I'm kind of sad about the policy environment, to be frank. I mean, I always quote the former Harvard president, Larry Summers, when he was talking about biotechnology. And he said, if biotechnology were art, we were now in the high renaissance. We're in the greatest period of discovery that's ever happened in human history. And there's not an appreciation for it in the policy community. The policy community is saying we got to ratchet this down. You know, Bernie Sanders up there talking about importation and all sorts of things that doesn't encourage innovation. And we should be recognizing what an important moment this is and encouraging it.
We have more ability to improve health for all families, whether they have low healthcare needs, high healthcare needs, whether insurance makes sense for them versus paying cash direct. You know, we have this immense ability to improve people's wellness, more than we've ever had before. And we're spending an awful lot of money on it. So much of that money is going into places where we don't even know it's going. Right? We don't know what the real prices are. We don't know what the rebates are. We don't know what the discounts are. And platitudes of price caps just are not going to fix anything. We've got to dig a little deeper.
Yep.
It's hard.
Well, I want to thank everybody on behalf of the Pioneer Life Science Initiative for joining this conversation. We hope that you found it insightful. We hope that you'll participate in another conversation in the very near future.